So again, before I go on to this slide, I just want to reference you to the differential white blood cell count handout that I have created for you in your packet, in your study guide, that has the normal white count, of course, 4,500 to 11,000. It has the critical values, less than 2,500 or greater than 30,000. It also emphasizes that all of the total of leukocytes will produce a total of 100%. And then also want to highlight that the neutrophils and the lymphocytes, those two categories alone make up 80 to 90% of all leukocytes. So when we look at these next couple slides and look at some actual lab on patients, you will see that you will expect an increase in the neutrophils because those are the first to respond in acute infection and inflammation, and so that number is just logically going to go up. And when that number goes up, because the neutrophils equal 50 to 70% of the total, then of course the lymphocytes have to go down. And remember, the lymphocytes are your B and T cell immunity. Now, also, again, if they can separate out the segments and the bands, which I have on that table for you. The other cell that we haven't talked about much is the eosinophil. And on the handout that I have for you, this, if you see increased, primarily would be due to allergic or parasitic conditions. So we think eosinophils, worms, wheezes, and weird diseases. So worms, parasites, wheezes, as we think of with inflammatory or allergic responses with that. Again, then you'll see the lymphocytes, and then a small percentage are the monocytes or the mature macrophages. Now on this slide, this is the left shift. So all this is comparing the percentage of immature to mature neutrophils. And so left shift indicates an acute bacterial infection. It indicates that there are more immature neutrophils bands that are being released from the bone marrow due to the mature segs being used up. So the bone marrow will release the bands or the immature because the mature ones are used up. So it just sends them even though they're not fully mature yet. So that's what the left shift will mean. So this slide does a nice job. You can see the normal bands is 3 to 6, and again the bands are the immature, and then you'll see shift left, they'll be elevated at 10%. The total neutrophils or the segs you'll still see typically are elevated, the mature, but you will see when as soon as those bands increase the immature, then you know the bone marrow is sending immature cells out, and that is what we call a left shift. So these were clinical labs from a patient quite a few years ago, but it still is the same as far as how it looks. White blood cell total we see is 13.5, so we see that that's slightly high. This particular patient had a ruptured appendix, as you can see. Then if we go down to the differential, you'll see again the neutrophil P, the lymphocyte P, the monocyte P, eosinophil P, basophil P, and then it repeats all those with the N. So again, we're just going to look at the percentage because they're really going to associate in the same way, so it is kind of irrelevant to look at both. So most of the people will just look at the percentage. So we see the neutrophils percentage is up, and that's just indicating that that's a normal inflammatory response, that more neutrophils went to the site of infection, inflammation, etc. And then again, because the neutrophils and the lymphocytes, and they sit side by side on the differential at most facilities, again, depending on how they report the labs, but we'll look for the lymphocytes. When we're looking at the neutrophils, we'll look at the lymphocytes too, and typically the lymphocytes will go down because remember the neutrophils and lymphocytes together equal approximately 90% of all of the total white blood cells. If we look here, again, this was a ruptured appendix. 8/8 was the day of surgery, or day of admit, and day of surgery, and 8/10 was 48 hours after surgery. So I wanted to point out when you look at the total WBC, you see 19.7 initially high, and you see it coming down nicely to 8.3 within 48 hours after surgery, which is showing that inflammatory response essentially. Again, we're going to be watching for the trending because with a ruptured appendix, they of course are at higher risk for abscess formation and infection down the road. So in 7 to 21 days, if we are having increase in WBC along with signs and symptoms and fever and things like that, well then we might be concerned about that. But I want to take you to the manual differential, which is separating out the bands and the segs. And remember, the bands are the immature neutrophils and the segs segs are the mature neutrophils. So here you will see the bands. There is 16% of immature neutrophils. So this patient is showing a left shift, or was showing a left shift on 8-8, where there were more immature neutrophils being released. The other thing on the very bottom is the SED rate. Remember, the erythrocyte sedimentation rate just shows an acute inflammatory response. It's not specific to any one condition or any type of inflammation, but that we know to always think of the SED rate as indicating, if it's high, that there is inflammation occurring. This next patient has cellulitis, and again, you can see the WBC here is 6.2, so the total WBC is normal, but you can see again the segs, which are the mature neutrophils, are high, but the bands, the immature ones, are normal. So in this case, this shows that the patient has mature neutrophils that are helping to try to fight the infection with a total increase in neutrophils, but not a left shift happening. I have added this just to show you that we do cultures and blood cultures for anybody who has a serious infection or sepsis, and so those cultures and sensitivities will come back, and you see the susceptibility is gram positive, so S equals sensitive, I is intermediate, and R is resistant. So this is how the pharmacists help to decide that they are on the appropriate course of antibiotic. With inflammation, we've talked mostly about an acute inflammatory response, and again, that's our main protective function, which is why we've talked about it with our immune response. And again, that's usually less than 2 weeks, but just know that there are chronic inflammatory conditions. We'll be getting to some of those that basically, when it's chronic like that, they don't really have a protective function, and they can lead to scarring and permanent tissue damage, such as rheumatoid arthritis, and we'll talk some of those rheumatic diseases that have chronic inflammatory response going on. The final line of defense, then the third line of defense after the skin and mucous membranes as 1, inflammatory response as 2. Our third is our adaptive or acquired immunity, which is our specific immunity that involves the lymphocytes, that involves the B and T cells. So the lymphocytes are the Bs and the Ts. The humoral immunity is our antibody mediated. So I think of antibody, the B, and antibody mediated to remember the B cell are working in that regard, and then the cell mediated is the T lymphocytes that are working, and we'll talk more specifically about each of these. The other thing to remember, in the picture you can see the bone marrow is responsible for releasing the stem cells that then are going to release those B cells, so bone marrow, B cells, and then the thymus is responsible for the T cells. So humoral or antibody immune response, again, is a specific form of immunity. It provides long-term protection because we have the B memory cells. So the B lymphocytes are produced by the bone marrow. Again, we have plasma B cells that are going to bind to the specific antigen. So when we have an antigen, an invading bacteria, virus, tumor, etc., the antibody is going to form to that, and it's very specific to that specific antigen, and it's going to bind to it, and then that's how it will render it harmless so that it can't multiply or spread. The memory B cells then are going to stay in your body for life, and this is going to help provide long-term protection. Again, we have one antibody for every one antigen. It is very, very specific. So it will respond to that same antigen by producing an antibody if it should see it again in its lifetime. So again, antibodies are very specific proteins. They disable the invaders. They bind with that specific antigen and render them harmless. So B cell immunity is the antibody immunity, or also known as the humoral immune response. So this picture is showing the B cell immunity, the B cell lymphocyte immunity, the antigen antibody response. So it's like a jigsaw puzzle. It's an exact fit. Each antigen has an antibody that fits exactly with it. Again, the antibodies are produced by the B cell lymphocytes, and they bind with the specific antigens, rendering them harmless. I also like this picture because it tells the story of the B cells finding the antigen and finding that exact match that we've talked about. But the other thing that it does is the B immunity does send out a message, and the activated T cells are going to come and help out with the B cell. So even though B cell is a different type of immunity than T cell, they're all working together. It's not like one starts and one stops, etc. They're basically starting and kind of working collectively, if you will. So the B cells are going to activate that T helper cell. And again, if you look at number 5, the eater cells, this is basically how they're going to eat up and load those as it responds to that specific antigen. So we have indicated that humoral immune response produced by the B cells is an antibody-mediated response. So this basically shows the types of antibodies, or what we call immunoglobulins, that are produced by the B cells. So you have all the various types: IgG, IgA, IgM, IgD, and IgE, and it has the percentages. Again, you don't have to worry about exactly all of the amount and all of that, but you should note that IgG is 75% of our immunoglobulin or antibodies that are formed and that we keep in that memory area. So IgG is a major role in bloodborne or tissue infections. So if some people have different immune responses or immune diseases where they have a low amount of their own IgG, they would be more susceptible to infection and have more difficulty with bloodborne and tissue infections. So we will talk about some of the conditions where they may need to go into infusion therapy to get IgG infusions and or IgM infusions. So either way, we'll be taking a better look at that. We will also, if you look at IgA, that's the antibody that neonates get through breast milk. And so that is the immunity that moms are providing if they are breastfeeding to their newborns, is the IgA. And then IgE is one, again, if you think of the E, eosinophil type white blood cells, the IgE antibody is also associated with allergic reactions and parasitic conditions. So worms, wheezes, weird diseases. You can think of IgE and eosinophils, both would be high with allergic reactions and parasitic conditions. And finally, the last immunity in that third line of defense is the T cell, or the cell-mediated immune response. Again, this occurs once the pathogen is inside the cell. It is, again, mediated by the T lymphocytes. We have 4 different types of the T cells that you can see there: the T helper, the T cytotoxic, which are killer cells, the T memory, and the T suppressor cells. They all have various functions, but again, this is going to react directly once through the antibodies. Once we have the B cells, remember, are activating the T cells to come and help, and the T cells will kind of coordinate then and kill and help, etc. Remember, the T cells have memory cells as well, so it's very specific, and also they are helpful in defending against viral, fungal, parasitic, and other types of things, even things like mediation of transplant rejection, etc. Because the T suppressor cells, this is a cell that's important to sort of suppress the immune response enough where we're not overreacting to our own body. So this is helpful with autoimmune disorders and certainly helpful for transplant rejection, for example. This more specifically shows how the T helper cells activate the B cells to produce the antibodies, and then also activate those cytotoxic or killer T cells that can help with the phagocytosis. So again, the killer cells are gonna terminate the cells that are infected with viruses, bacteria, and also help with killing of cancer cells. And then we also have the memory T cells and the suppressors T cells. So again, the memory T cells will have a faster and stronger immune response with subsequent exposure to that antigen. And then the suppressor T cells, like I mentioned before, are going to inhibit our own immune response to antigens once the pathogens are eradicated. So this will prevent overreaction of the immune response, which we see with hypersensitivities and some of our autoimmune disorders. And finally, a cell that we haven't talked about yet are natural killer cells. These are in the lymph system, and these are non-B and non-T cells. So they are basically another cell-mediated immunity that they are capable of a very rapid response without prior sensitization. So they are basically your surveillance, like your X-ray vision, where you can basically kill target cells without a need to recognize the antigen. So they will directly kill certain tumors, melanomas, lymphomas, etc., virus-infected cells, and so they are very, very helpful to our immune response. So now that we have talked about what we did, hopefully this makes sense. This third line of defense here is showing you the diagram of the bone marrow and the bone marrow maturations to the B cells, and then the thymus that helps produce the T cells. But either way, it's just showing you that we have various different T and B cells, and how, while they are separate different responses, a humoral or an antibody-mediated and a cell-mediated response, they are essentially working side by side, hand in hand, to help fight our body. And again, the T cells, the T suppressor cells that are also encouraging or suppressing the immune response so that we don't have overactivity of actually killing our own healthy cells. So before moving on, I do want to again refer you to the responses to the immune system table that I've created in your study guide that basically specifies the specific and non-specific lines of defense, and then separates out specifically the humoral and cellular immunity. So I hope that you find that table helpful to sort of summarize many of the slides that we have talked about thus far. So moving forward, this slide then basically is going to separate out the different forms of immunity. So you'll need to know whether or not the immunity is a naturally acquired or artificially acquired, but then also if it's a naturally acquired active or naturally acquired passive. So just going to take some time, just going to need to spend a little time to focus on this and make sure that you remember learning this before. So the naturally acquired active is going to be if you contract a disease such as the chickenpox, and then you develop the antibodies against that for the future. So, or like if you get influenza A virus, well, I'm immune from that same strain of that virus anyway for the rest of this season. So naturally acquired active. Naturally acquired passive will be breastfeeding primarily, and then what the baby is receiving through the placenta. So this will be an immediate but short-term passive immunity. Artificially active or artificially acquired active, this is where if we're giving vaccines, that we are basically giving them the synthetic antigen so that they can build up the immunity for that. So vaccinations, we are again giving them the antigen so their body can respond and make the antibody against that antigen. So that is artificially acquired active. And then the last one, artificially acquired passive, would be if we are actually giving specific antibodies in the serum. So this would be your IV immunoglobulin infusions, for example, for treatment of hepatitis, if we need to give IgG or IgM immunoglobulins to that patient. The correct answer here is C. This immunity is adaptive or acquired, and it is a long-acting. So typically this will last for many years, may need boosters for some vaccinations, but they typically will be more of a long-acting type of immunity. The correct answer here is B. This is a natural passive immunity. Passive immunity when we transfer an antibody from one person to another, such as what is happening when the fetus receives the maternal IgG antibodies from the placenta, and then the IgA would be the antibody that we are getting transferred with the breast milk. And this is short acting. It's immediate, but it's a short acting. Typically, most maternal antibodies dissipate in the infant by approximately 6 to 9 months, but may last up to 18 months, but more so most of it gone by 6 to 9 months. So that's a really nice bridge, if you will, while the baby is building their own immunity, to have that extra antibody that we get from breast milk. This patient has the chicken pox, so this is a natural active immunity. So the disease itself is going to stimulate that immune response to produce the antibody against that given antigen, and then they will have memory of that. So it's adaptive or acquired, and it is long acting. This would be an example of D, artificial passive immunity. It is adaptive or acquired, and it is short acting. This is the nurse preparing to give an immunoglobulin IgG via IV, and thus the body is not producing the own antibodies. They are receiving those antibodies passively. This type of immunity is humoral or B cell antibody mediated response. This is showing you the antigen antibody reaction produced by our B cells. So this would be under that humoral or B cell antibody mediated type of immunity. Again, that and the T cell immunity is our third line of defense. It's important to ask questions specifically about the patient's health history, nutrition, infections, immunizations, to gather information about how we think their immune system. How strong is their immune system, or are they looking like to be more immunocompromised? So we'll ask nutritional questions such as caloric intake. We'll definitely want to take a look at their albumin or total protein to see if there's any issues there. We know our total nutrition really helps with our immunity as well. As far as infections and immunizations, we want to definitely find out if they are up to date with immunizations or if they've been frequently having infections or more recently had an infection. We will definitely ask about allergies to food, drug, environment, etc. And then also see if they have any diseases such as autoimmune disorders, such as lupus, rheumatoid arthritis, psoriasis. Those are some examples of more common autoimmune disorders. If they have current cancer or history of cancer, do they have chronic illnesses which could put them at more immunosuppressed states? Are they on medications such as steroids that could immunocompromise them? And then have they had a transplant? Obviously, we'd want to be aware of that as far as transplant rejection. We'll definitely look at their age, the very young and the very old, more likely to develop problems related to the immune function than those in their middle years, so very young and very old. Again, family history, in particular cancers and autoimmune disorders that maybe have genetic predisposition, and then living conditions, especially if there's pets or dander or other sorts of allergens in that environment. Upon physical examination, we could palpate their lymph nodes. We know that lymph nodes are all over their body, placed especially axilla, groin. We think of our neck area and back of the neck area. So it's normal for nodes to feel movable and soft and non-tender, but if you feel them to be firm and not movable and more of a firm, fixed, and or tender, those would be an issue. Also, the time frame in which they're staying enlarged after an inflammatory process is part of a priority as well. You know, if we're ill, we might have enlarged lymph nodes for a few days to a week, but we typically wouldn't have our lymph nodes stay enlarged for, months, weeks to months. So that would be a warning sign as well. Now, we don't routinely feel lymph nodes on a head-to-toe assessment, but if we had somebody that was immunosuppressed, that had a recent infection, etc., and or that was having maybe some blood dyscrasias or blood abnormalities, we might check the lymph nodes for sure. We'll definitely assess the skin, mucous membranes, and all body systems. In particular, again, taking a close look at the red blood cells, white blood cells, and platelets, and seeing what those values would be. Certainly, if somebody has a low red blood cell, low hemoglobin, they might have more of a pallor to them, might have more chance of being fatigued. White blood cells, of course, we're checking fever, we're checking for any other signs and symptoms of infection. Again, if they have an elevated white count, is it inflammation? Is it infection? And if they have a low white count, well, then we know they're immunosuppressed and we're going to have to protect them from infection. And then platelets. If somebody has a low platelets, we know that's going to put them at higher risk for bleeding. So if people are immunosuppressed, they may have a low platelet, and we'll want to be watching for excessive bleeding, bruising, nosebleeds, etc.